Okay, great, great. Good morning. I'm George Minowata, your moderator today, and also a volunteer pulmonologist of MAVEN Project. Welcome you to today's session on type 2 diabetes, when to give which meds, which is made possible by a partnership between MAVEN Project and Direct Relief. It's my pleasure to introduce to you our speaker today, Dr. Craig Sadur. Dr. Sadur was an assistant professor of medicine at the University of Colorado Health Sciences Center and the chief of the endocrine unit at Denver General Hospital. Then after 9 years of private practice in endocrinology, he joined Kaiser Permanente, Northern California, where he practiced clinical endocrinology for over 24 years and received the Career of Caring Award for exemplary physicians. And with that, Dr. Sadur, the microphone is yours.
Okay. All right. Let me share the screen.
Dr. Minowata, you want to stop sharing your screen first?
Right.
Okay.
Okay, great. All right. Okay. Pulling it up there. Great. And okay. Thank you so much, Dr. Minawato, and thanks for everyone for being here. For what has been a very exciting topic for all of us who see patients in the clinic with this very common disorder, and a lot of very innovative changes. And as Dr. Minowata said, we'll have questions and answered at the end. So some of the questions that may pop into your head during the talk may be answered later in the talk. So type 2 diabetes, when to give which meds. And with today's objectives, recognizing the factors that direct which medicines for diabetes are optimal, and applying the drug treatments to improve the outcomes of type 2 diabetes-related complications, and choosing the medicines to assist patients who have other possible key issues for them. So much of the research has been gathered by the American Diabetes Association that every year comes out with their standards of care. So with type 2 diabetes management, the main areas of approach for helping patients are medical nutrition therapy, which optimally would be with the assistance of a registered dietitian, weight reduction, because about 80% of patients with type 2 diabetes are overweight, if not frankly obese, exercise, medications, optimally working with a diabetes educator, and surgery. But for today's purposes, we're going to focus on medications. So to individualize medicine choices, if the patient has or is at risk for having atherosclerotic cardiovascular disease, heart failure, chronic kidney disease, hypoglycemia concerns, cost concerns, weight concerns, and hyperglycemia-related catabolism. So really, at the very beginning, when you assess the patient, it gives direction on how we can best focus therapy for this individual patient. So with type 2 diabetes, the blood glucose lowering medicines, looking at them, in the old days, which weren't that long ago, it was metformin. You go to metformin, and if that worked, great, sugars were good. If not, you added a sulfonylurea, and if that worked with the two meds, okay. But if sugars were still up, then you went to insulin, and that was pretty much it. And then after that, metformin still remained the first choice of therapy. But now, as you folks have seen, things are very different. You choose medicines based on comorbidities, weight, A1C lowering, hypoglycemia risk, efficacy, adverse events, tolerability, cost, patient preferences, and symptomatology. So it's much more nuanced than before. And it's not that metformin has been completely bumped out of the situation, but it's no longer the automatic go-to first choice. And if possible, a preference for simple medication regimens, such as the once-weekly glucagon-like peptide 1 receptor agonists. This is a very busy chart that I don't expect you to look at today, but as Dr. Minowata said, he's going to make sure you get the slide set. And I'm just going to direct you to a couple of things. These are the medicines in this column: metformin, SGLT2 inhibitors, and all through to insulin. And then the different properties: efficacy, hypoglycemia, weight issues, cardiovascular effects, renal effects, route of administration, costs, and other considerations. So it's there for you, excuse me, it's there for you to be have as a reference. And this came out within the year. Therapeutic inertia is something that it helps all of us to keep in mind. And specifically, to quote what came out of the American Diabetes Association, to avoid therapeutic inertia, reassess and modify treatment regularly, 3 to 6 months. It's very easy for any of us to just have the patient go along, keep renewing meds and such, but it's always worth looking at it with as fresh eyes as possible to see what changes would be best. Let's go through some cases. Okay, case number 1, a 32-year-old Black female. Now, different ethnic groups, such as Black patients, have an increased risk for metabolic abnormalities, such as type 2 diabetes. This patient presents with vaginal discharge following antibiotic use. Antibiotic use are one of the main risk factors for women to develop vaginal infections. But let's look a little further. She doesn't have any other symptoms. Family history: she does have type 2 diabetes, and type 2 diabetes has very strong genetic tendencies. So when you have someone with it in the family, it just raises suspicion this patient could be a risk. Social history: she occasionally uses tobacco. Physical exam: her vital signs are normal. Her her BMI is elevated. She is obese with 31, and the distribution of her fat tissue is she has abdominal adiposity, which has been associated with increased atherosclerosis. So there's concerns right away. In addition, with the lab, you do your office evaluation, and it turns out she does have a vaginal candidiasis. She's got a fasting blood glucose of 126. And her A1C is 6.6. The rest of her comprehensive metabolic panel is unremarkable. So a fasting blood glucose of 126, if you do 2 different days fasting sugar and it's over 125, that meets the criteria for diabetes. But she also meets it on the basis of A1C because it's 6.5 or greater. So she does have diabetes. So she's got the family history. She's obese. She's got one acute complication of it with candidiasis. And so what do we do? Well, we want to counsel her first on healthy diet, physical activity, weight management, smoke cessation. Even though she only uses occasional, it'd be good to get that risk factor out of the picture. And measure the lipids. And the lipids panel, as you've seen, total cholesterol, triglycerides, HDL cholesterol, LDL cholesterol. If possible, it would be ideal to do it fasting because then you get a more interpretable triglyceride level. And she'd be a candidate for metformin. She's of reproductive age. Pregnancy and breastfeeding are not contraindicated for metformin. And it's actually an off-label use for gestational diabetes and polycystic ovary syndrome, which is the most common endocrine abnormality in women. It is an off-label use for PCOS patients who have oligomenorrhea. With metformin, even though it's not the #1 go-to meds, it's still part of the armamentarium and it's got benefit. Be aware of a couple of things regarding A1C and B12. It lowers A1C some. It lowers it a little over 1% as monotherapy, about 1% when it's added to another oral agent, and about 0.6% when it's added to insulin. So it does go in the right direction, not dramatically, but some. And it's important to monitor B12 levels because patients may become B12 deficient on it. So at least yearly, keep a tab on that. This is the second very busy slide that, again, you'll get in your slide set. And this is from the American Diabetes Association, and it's the glucose-lowering medication and the management of type 2 diabetes. And it gives pathways. And I just want to point out some things with it. The first thing is the healthy lifestyle, which is always the cornerstone of therapy. And diabetes self-management education, the more patients know, the better off they are. And then these social determinants of health have, as you folks have seen in clinic, but now it's becoming more upfront in terms of recommendation. These are economic factors, healthcare access, environmental issues, the things that are very basic that can interfere with good care for patients who have diabetes. Let's do a second case. A 41-year-old Latino, and again, Latino patients, as with Black patients, have an increased risk of these abnormal metabolic, really insulin-resistant conditions, type 2 diabetes, dyslipidemia, hypertension. So this patient presents with a family history of atherosclerotic cardiovascular disease. And what is that? His father had a myocardial infarction at a very early age, 51. His maternal uncle had a cerebrovascular accident at age 59. So this patient, unfortunately, has the double whammy. He's got atherosclerotic disease in both sides of his family. His mother has had papillary thyroid cancer. Social history, he's sedentary. His blood pressure 132/82. He's overweight, not quite obese, but he's close, BMI of 29. He's got corneal arcus, and his labs show that his fasting glucose is 209, his A1C is 8.7. So he definitely has diabetes, and it's in poor control. And his estimated glomerular filtration rate is decreased. It's 29. So what do we do for this gentleman? Well, we want to counsel him with lifelong healthy lifestyles, improve nutrition, hopefully lose some weight so he's more insulin sensitive to his own pancreatic secretion, and to exercise, which has multiple benefits and even non-insulin mediated glucose benefits with that. And measure the lipids, ideally fasting, so we can see where he is. And for him, a GLP-1 receptor agonist would be a consideration. Now, in terms of his decreased eGFR, an SGLT2 inhibitor for glycemic control really wouldn't be very effective for patients who had the eGFR below 45. Now, you can get some renal protection with eGFRs as low as 20. You don't get as much renal protection as you would when it's higher, but you do get some. But at that level, we don't expect any glycemic control benefit. And it's recommended to avoid starting metformin if the eGFR is 30 to 45, and his is 29, so he's not a metformin candidate. And if a patient has already been on metformin and drops the eGFR below 30, you want to stop the metformin. So GLP-1 receptor agonist is an option open to him. What about blood pressure medicine? His blood pressure was 132/82. Well, in hypertension and diabetes, there's certain considerations. And it's recommended that all hypertensive patients with diabetes should monitor their blood pressure at home. And the blood pressure target would be less than 130/80. I like to tell patients, shoot for the 120s/70s. So they don't hear the 130/80, because then it's like, oh, 134/84, that's not bad. 120s/70s. Now, the caveat is if it can be safely attained. And if you have let's say an older, frail patient, that blood pressure may be too low, may cause symptoms. But for the vast majority of patients, if you can get them down to that, you have definitely lowered their risk of complications. And this is the atherosclerotic cardiovascular disease risk estimator. This one comes from the American College of Cardiology. It's on the web, free of charge. You folks have seen it. And as you've seen, it's easy to fill out the age, the gender, the race. Now, race right now is white, African American, or other. Hopefully, not too long in the future, there'll be more ethnicities that will be available to see where their risk is. But that's what we have at this time. Systolic blood pressure, diastolic blood pressure, total cholesterol, HDL, LDL. Now, you don't see triglyceride, but if you have a patient with very high triglycerides, the LDL may not be part of the lipid panel, because if the lab relies only on calculation, they will not be able to calculate it. If they have direct measurement, they will. History of diabetes, yes, no. Smoker, current, former, never. On hypertensive treatment, yes, no. Statin, yes, no. Aspirin, yes, no. So pretty easy to fill out. And then you can get the chance within the next 10 years of the likelihood of a patient having a cardiovascular event. Okay, back to the pathway of the glucose lowering medications. Rather than go to metformin, as not too long ago, the recommendation is immediately look at comorbidity for cardiorenal. And the question is, does this patient already have this, or is the patient at high risk? So that's your go-to for what medicine do we start with? And this is a drill down. This is a magnification of that slide for the upper left part. So cardiorenal. So if the patient has atherosclerotic cardiovascular disease or multiple risk factors, and we saw this patient's family history, hypertension, and for all we know, dyslipidemia. So this tells us that for him, a GLP-1 receptor agonist or an SGLT2 inhibitor would be the way to go. But again, with eGFR being low, that tilts the scale toward the GLP-1 receptor agonist. Okay, so we've got a pathway with him. And again, there's other patients who will go down different parts of the chart. So with the GLP-1 receptor agonist with proven cardiovascular benefit for type 2 patients with cardiovascular disease, the outcomes got better when they got liraglutide, injectable semaglutide, and dulaglutide. So you're not only giving the medicine to lower the glucose, because that used to be not many years ago, really not only the main thing, sort of the only thing that was directing treatment. Now we think early for reducing complication risk. So that's why going to one of these other drug categories. And the GLP-1 receptor agonist with type 2 diabetes, not only cardiovascular benefit, but all-cause mortality is decreased in patients who have type 2 diabetes and established cardiovascular disease. But you want to avoid GLP-1 receptor agonists if you have a patient with type 1 disease, past pancreatitis, if you have the, oops. Okay, I'll try and keep my fingers off the keyboard. If for a couple of the GLP-1 receptor agonists, you avoid it if the eGFR is very low, but most of them you can give it. If you have severe GI disease, such as gastroparesis, it'd be best to avoid a couple of them, if not all of them. Now, this patient, just to remind you, mother had papillary carcinoma of the thyroid. If you've had a family history or a personal history of medullary carcinoma of the thyroid, then you don't give a GLP-1 receptor agonist. So it's a common question going, there's thyroid cancer in the family. Does that mean we can't give the med? Well, fortunately, the medullary carcinoma of the thyroid is rare, either individually or as part of the MEN 2A or 2B. So for those folks, you don't give it. But run-of-the-mill papillary thyroid cancer in the family, you can definitely give GLP-1 receptor agonists. Okay, case number 3. 62-year-old Native American female. Native Americans, like Latinos, like Blacks, have an increased risk of metabolic disease such as type 2 diabetes. This patient already has a diagnosis of type 2 diabetes and heart failure with a reduced ejection fraction. She's done her homework. She's requesting semaglutide, the GLP-1 receptor agonist, to lose weight. And on exam, she is obese. She's got a BMI 31. You've done a monofilament 5.07 test to sense how she feels in her plantar feet, and it is decreased. But fortunately, she has normal pedal pulses and no foot ulcers. She's got an A1C of 8.1, suboptimal control. She's got renal insufficiency with an eGFR of 44, and she does have left ventricular ejection fraction decrease at 39%. So she's got type 2 diabetes, she's got heart failure, and she's asking for a GLP-1 receptor agonist. Turns out there's no data to show they're effective with heart failure. And that's why that's not the best medicine for her overall health interests. But SGLT2 inhibitors do have benefit for heart failure as well as chronic kidney disease. Canagliflozin, dapagliflozin, and empagliflozin all help patients with heart failure. And she's got an eGFR of 44. She could take canagliflozin. That would be the one SGLT2 inhibitor. So heart failure, points you toward SGLT2 inhibitor. Her CKD, it's not terrible, but it's certainly significant. You can give canagliflozin. So that would be the recommended medicine for her. So with heart failure and peripheral arterial disease, it's recommended to screen. And this is new in the guidelines that have come out for patients with diabetes. With heart failure, consider screening adults with diabetes with a BNP or the NT-proBNP to screen them for heart failure in order to prevent stage C heart failure. So if you have a patient who's asymptomatic and has abnormal BNP levels, then it's recommended to check an echocardiogram to identify stage B heart failure. Why? First of all, patients with type 2 diabetes, unfortunately, have a high risk of developing coronary artery disease, other aspects of cardiac disease. And now there's a treatment, the SGLT2 inhibitors. So rather than have them present later on in florid heart failure, you want to pick them up early so you can mitigate the complication. And for peripheral arterial disease, which also is relatively common in diabetes, if the patient's asymptomatic and 50 years or older and has any microvascular disease, retinopathy or diabetic kidney disease, or foot complications or any end organ damage, it's recommended to screen for peripheral arterial disease with an ankle brachial index, and an ABI 0.9 or less is abnormal. And the idea is they probably have cardiovascular disease because having arterial disease in one area puts you at higher risk for other areas, and of course, limb preservation. And if you have a patient with type 2 diabetes, we're talking about 10 years or greater, consider screening. So it's an easy screen test, and it can, for that given patient who has disease, make a big difference. So the cardiac benefits with SGLT2 inhibitors, empagliflozin and canagliflozin, decrease the morbidity and mortality. And with type 2 diabetes and heart failure, all of the SGLT2 inhibitors show benefit, especially when there's reduction of ejection fraction. So case 3, lifestyle counseling, always the cornerstone of therapy. Even though she came in asking for a GLP-1 receptor agonist, in her best interest, it would be an SGLT2 inhibitor. You want to improve the glycemic control. And part of selling it to her is, it doesn't mean she'll never get a GLP-1 receptor agonist. I mean, you want to do lifestyle measures, try and get the weight down, but it could always be added later. And if she's a candidate. Foot care education is important. Okay, case number 4. We've got a 65-year-old South Asian female, type 2 diabetes for 20 years. eGFR is decreased at 35. Urine albumin is increased to 250. So she's got an ethnic group that also has very high atherosclerotic cardiovascular disease risk, the South Asians, Indian, Pakistani. 20 years of type 2 diabetes, very common time to have microvascular disease such as renal disease. And with the eGFR of 35, the only SGLT2 inhibitor for which she'd be a candidate is canagliflozin. And we're thinking of an SGLT2 inhibitor because she's got already diabetic kidney disease. And the standards of care also call for patients to get an ACE inhibitor or an ARB if they have any kind of albuminuria. And normal depends on lab, goes up to 29. So if you get any above that, you're trying to slow down the progression of renal disease. And these medicines have been shown to be effective for that. So the properties of SGLT2 inhibitors, it basically decreases glucose reabsorption in patients who are urinating out glucose. Decreases hyperglycemia with that slight osmotic diuresis. We don't expect hypoglycemia in these patients. It acts as a weak diuretic. Early in the treatment, and this is important to keep in mind when you see those labs, you may get a worsening of the eGFR, but that doesn't mean you stop the medicine. A lot of these patients have a hyperfiltration of their glomeruli, and that's part of their disease process. So you're treating them, their eGFR responds, it shows that they've improved from their hyperfiltration, but the prognosis is better. They maintain their renal function better than if they didn't have the SGLT2 inhibitor therapy. And it's recommended that consider it for any patient with type 2 diabetes who has renal disease. And it helps with weight loss. So for this patient who came in asking for a GLP-1 receptor agonist, we do expect some weight loss with SGLT2 inhibitors and also improved blood pressure. Precautions are similar to metformin. When you get an acutely ill patient who ends up in the hospital or, let's say, needs to have contrast with intravenous imaging preparation, withhold the treatment just to prevent problems because of volume changes. And patients like the oral route. That's a crowd pleaser. So SGLT2 inhibitors in diabetic renal disease, we have a number of medicines, excuse me, that decrease the progression of renal disease. And it's less benefit if they have more severe renal insufficiency, but it still can help if people have eGFRs down as low as 20. Now, there are reports of acute kidney injury. This came out early, and some required hospitalization or even dialysis, and that was with a couple of them. But upon further evaluation, it's often within less than a month of drug initiation. But then there have been subsequent studies that show the SGLT2 inhibitors didn't really vary from the non-users in terms of acute renal injury. So it may not be an increased risk, and maybe the old data was misleading, but since it's out there in the medical literature, at least let patients know that yes, there have been reports. It may not be increase in incidence, but something to keep in mind. So the SGLT2 inhibitors with chronic kidney disease and mortality benefit, they help. They reduce diabetic kidney disease progression, and they decrease overall mortality. So similar with GLP-1 receptor agonists, we're lowering sugar and we're helping our patient reduce further complications. But you want to consider avoiding type SGLT2 inhibitors if you have a patient with type 1. If there's a past diabetic ketoacidosis or risk, pancreatic insufficiency, drug or alcohol addiction, or someone who's on the ketogenic diets, excuse me, if they have propensity to bacterial urinary tract infection or genitourinary yeast infections, they can get worse with SGLT2 inhibitors. If they have low bone mineral density or high risk for fractures and falls. And what's in red is what applies to this patient. She had the abnormal peripheral nerve testing with decreased sensation. Now, it's not an absolute contraindication, and this is where judgment comes in. If she had decreased sensation, but the rest of her foot exam was okay, and she had significant renal disease, you could talk to her, shared decision, say, you know, there's a potential risk for foot ulcer, but this is an opportunity to help the patient understand, take great care of your feet, watch them, never go barefoot, good fitting shoes, inspect your feet, etc. And any problems, let you know. But all things being equal, maybe this wouldn't be the best choice of medicine for a patient at foot ulcer risk. Microvascular with GLP-1 receptor agonists, it reduces nephropathy outcomes. And one thing to keep in mind is injectable semaglutide increases retinopathy. So that's the one GLP-1 receptor agonist I wouldn't give to a patient who has diabetic retinopathy. You can give oral semaglutide, but not the injectable one. So with renal disease with type 2 diabetes, the go-to medicine has been the SGLT2 inhibitors, but a very reasonable alternative is the GLP-1 receptor agonists. And both of them in terms of glycemic effect work some. SGLT2 inhibitor 0.4 to 1.1% drop in A1C, GLP-1 receptor agonist, pretty similar. So they help. They're not dramatic in terms of getting patients well controlled, but they help. So they can be monotherapy or they can be added on to another diabetic medication. Okay, again, looking at the slide, we've gone through the left side where we're looking at cardiorenal complications, but now we've addressed that. If we still have glycemic and weight and other issues, there's pathways for that. Case number 5, let's see how one of those pathways looks. We have a 90-year-old Chinese male. He's had type 2 diabetes for 4 years, passed excellent control. until 10 years ago when it was determined that he had dementia. Increased hypoglycemia frequency, including a recent severe episode, which is always a concern. He lives alone. He checks his blood sugars, but he may forget his treatment dose. And his medicines include MPH insulin, regular insulin, and glyburide. So he's a hypoglycemic, not just risk, he's had hypoglycemia, including the one severe one. So we've got options. A GLP-1 receptor agonist, an SGLT2 inhibitor. We don't expect hypoglycemia with them. A DPP-4 inhibitor, we don't really talk about as much because there's no data that they help the cardiorenal complications, but in terms of hypoglycemia, we're not expecting it with them. Thiazolidine diones like pioglitazone, we don't expect hypoglycemia. Sulfonylureas, we do worry about hypoglycemia, and if you can avoid them, that's fine. But if you have to give them, go to a newer one like glipizide. And insulin, if you can avoid it, great. But if you do need to give it, you could choose an analog over MPH and a fast-acting insulin over regular insulin because there's some decrease in hypoglycemia risk. Okay, back to the pathway. So for patients with hypoglycemia risk, we've got approaches, okay, with that. So that's a pathway for this gentleman. And this is that really busy chart at the beginning, just to point out we've got hypoglycemia, and it's just the sulfonylureas, insulin, meglitide, which is not a common drug category that's used, but these are the ones. The rest, we don't expect that. So, new case. 35-year-old Pacific Islander. As with Latinos, Blacks, Native Americans, Pacific Islanders do have increased risk for type 2 diabetes and other insulin resistant factors. He's had diabetes type 2 for 5 years. His treatments evolved. He started with diet and metformin, then a sulfonylurea was added, and then insulin was added. And his weight keeps increasing. We've seen that. You folks have seen that. And now his BMI is up to 40, which is severe obesity. And his current dose, he's on a fair amount of insulin, although we see people needing a lot more. 60 units of glargine once daily and 20 units, which he takes with meals, aspart 3 times a day. And despite that, his sugars are not well controlled. His fasting sugars commonly go up to 200s and his A1C is 9. So we don't know what his insulin requirement is. It may be many, many units more than he's taking now. But with diabetes mellitus treatment and weight changes, the ones you worry about gain are sulfonylurea, thiazolidine diones like pioglitazone, and the insulins. There's neutral ones like the DPP-4 inhibitors. And loss, metformin, you may lose weight. It's at least neutral for weight. But the GLP-1 receptor agonist, as we all know, can cause a weight loss that can be dramatic. The SGLT2 inhibitors and the new kid on the block, the GIP, GLP-1 combination medicine like tirzepatide. So GLP-1 receptor agonists in type 2 diabetes and weight loss, it's been shown that a number of them are related, and patients, see the TV commercials and they get it in the news, and they do work. They do work. We don't know the long-term effects, but they do work. So there is an arm in the chart for weight management. So lifestyle, again, all of us, it behooves all of us to keep that in mind rather than automatically jump to the meds. Weight management programs, medication, and if need be, if they're candidates, bariatric surgery. And it goes through different medicines in terms of efficacy for weight loss. So this is a list of the GLP-1 receptor agonists. We've got the short-acting ones that are given exenatide twice daily and lixazenatide, liraglutide once daily. We've got the long-acting ones. Again, patients really like that if they're going to be doing injectables once a week. Exenatide has a long-acting form, dulaglutide, semaglutide, and there's one oral, the semaglutide, which comes in injectable and oral. And the SGLT2 inhibitor, we've got empagliflozin, canagliflozin, dapagliflozin. Those are the ones given most commonly in this country. So we've got options with that. And it depends on the patient's insurance and if it's Medicaid, and it's a very local phenomenon, what's in your area. But there may be one medicine of each drug class that may be approved for a given insurance plan. And that would be the medicine that would be available for the patient. Okay, case number 7. 55-year-old Caucasian female. She's had type 2 diabetes for 15 years. Unfortunately, she lost her job, and sadly, with that, she lost her health insurance. So her medicines, metformin, semaglutide, but no longer can she have coverage for that because of her insurance loss, and she's unable to refill it. So cost is definitely an issue. So regarding cost, metformin, inexpensive. Insulin, human insulin costs less than analog. Sulfonylurea's been around for decades, inexpensive. Thiazolidinedione, which interesting, pioglitazone does have a benefit in one particular area, which is pretty common, which used to be called non-alcoholic fatty liver disease. And now it's got the name of metabolic dysfunction associated steatotic liver disease, 20 syllables. But a lot of the patients with type 2 diabetes have fatty liver. And unfortunately, that's at risk for non-alcoholic steatohepatitis, which is now metabolic dysfunction, steatohepatitis, which can lead to cirrhosis, which can lead to hepatocellular carcinoma. So it's rapidly becoming the #1 reason in this country for needing a liver transplant. And there is a FIB4 calculation, which is through the internet. You can calculate through simple blood tests its likelihood that if this patient has severe fatty liver disease. But thiazolidinedione is the one medication that beyond the others helps. So it's got multiple benefits. Okay, case number 8. 44-year-old Latina female presents with a 20-pound weight loss, polyuria polydipsia. On exam, she's slightly orthostatic with hypotension. She's got severe obesity with a BMI of 40, generalized distribution of her adipose, increased velvety pigmentation of her posterior neck, axillary, and inguinal region. And in a lab, she's got positive urinary ketones to the moderate range. She's got a random blood glucose of 400, and she's got A1C of 14. So she's got unintended weight loss. She's got symptomatic hyperglycemia. She's got some volume decrease on exam. And she's got labs that show she's probably had the diabetes for quite some time, but it went undetected until she really became symptomatic. And here's her velvety lesion, and that's pretty classic for acanthosis nigricans. And that's a condition where patients have significant insulin resistance. So this is a patient who, not a surprise, became significantly hyperglycemic and symptomatic. So what's not on the standards of care chart that I've been showing you, where we went through cardiorenal complications, hypoglycemia risk, weight issues, is what to do when you have a patient like our last case. And you want to think insulin therapy if you've got catabolic symptoms. She's got unintended weight loss. She's symptomatic. I mean, she's losing the battle. She's breaking down fat, which for some patients may sound like a good idea, but she has a pathologic rate of doing it because fat is not as easily used fuel as glucose, where you can get glycogen stores. She's depleted those. Now she's breaking down fat because she cannot access her own glucose. Ketonuria, so she's got a starvation ketonuria, and severe hyperglycemia, which by arbitrary cut points have been listed at fasting plasma glucose greater than 250 or random plasma glucose of greater than 300. And an A1C of greater than 10. You know, recall earlier in the presentation how GLP-1 receptor agonists and SGLT2 inhibitors and metformin can lower A1C some. And it's good. It's the right direction. It's helping glycemic control, and hopefully with lifestyle, that would be all that's needed. But when you've got a really high A1C and the diabetes is poorly controlled, you're going to need insulin, at least acutely, hopefully other factors can kick in, but otherwise it's just not going to work. And certainly if diabetes type 1 is a possibility, you definitely want to go to insulin. So with this, in summary, comorbidities, practical issues, and hyperglycemia severity now direct treatment for type 2 medication choices. It used to be, let's get the glucose down. Once the glucose is down, great, we're there. And glucose is important, but these comorbidities, rather than wait until patients end up with myocardial infarction or needing dialysis, to get to them sooner rather than later. So in conclusion, glycemic control is still very important. I mean, we're always worried about microvascular complications, retinopathy, nephropathy. So getting sugars down is important. But so is selecting a treatment to improve the outcome of these type 2 diabetes-related complications. Just to let you know, this is something that's through the Endocrine Society. It's a mobile clinical practice guideline app. It's free of charge, always nice, free. And you can put it on your smartphone, and it has various categories, adrenal, bone health. Interestingly, it doesn't have much in the way of diabetes, and I think that'll change with time. But it gives you something that you can quickly access literally in your hand. And resources. So the Standards of Medical Care came out this January, and it comes out every January. And it's through the American Diabetes Association. You don't have to be a member. Every January it comes out, and it gives the updates where they take the world's literature and filter it down into recommendations. And patient resources, they can go on to American Diabetes Association and get lots of good information for them. And a special thanks to Kristen Talbot, our program manager, to Dr. Minawata for giving his time for moderating, to Dr. Einstein, our Senior Director of Physician Engagement, to, Shirley Severe Talon, our IT coordinator, who lurks in the background, bails us out when we need all kinds of things. And all these folks have done the heavy lifting, and they give us the easy job. Just to let you know, MAVEN project has various other talks related to diabetes mellitus. And if you're interested in any of them, reach out to Kristen Talbot, and she can connect you with another presentation. And this is from Shenandoah National Park. And with that, let me go ahead and I'll stop sharing the screen and open it up to questions.
Thanks, Dr. Sadur, for another fantastic presentation. There's some questions in the chat, one in the Q&A. Let me just start with the Q&A. We've seen significant hypoglycemia when adding SGLT2 inhibitors and GLP-1 receptor agonists to regimens with insulin. Can you comment on that?
Yeah, and that's exactly it. It's as monotherapy, we don't expect to see it, but add-on therapy, the good news is patient is getting some control of hyperglycemia, but it's an opportunity to lower the risk, lower the dose of insulin and or sulfonylurea. A lot of times if patients are on a sulfonylurea, their control is poor, they're on insulin, I just stop the sulfonylurea. It's probably not doing much of anything, and there's risk of weight gain, which a lot of these patients don't need. But if you have a patient, like you said, on insulin, and you add the SGLT2 inhibitor or GLP-1 receptor agonist, and they're getting hypoglycemic, dial down the insulin. And if the patient, let's say, really overhauled his or her lifestyle and now is great nutrition, losing weight, exercising, they may be more sensitive to their own insulin. And if you can lower the dose or even get them off insulin, that would be great.
Okay. Thanks. Let me move over to the chat. There are a number of questions. First, administrative. When we get the video of this presentation, can we share it with providers in our clinic? Great info and clear! Exclamation point. I believe the answer is yes, correct?
Yes.
Okay, great. Does the effect of ACE inhibitors and ARBs on renal protection vary by dose?
Yeah, that's interesting. So What you can do, I mean, obviously you want to follow serum potassium to make sure you're not getting into a problem with significant hyperkalemia. But I look at the urine albumin and I've gone up. Even patients normotensive with albuminuria are candidates for ACE inhibitors or ARBs. And I would give it to them and I would keep going. And if they do reach the highest dose, then you go, okay, we've done what we can in that modality and you know work on other things too.
Okay. Let's see. Yeah, I guess this is a question. Would you screen? I'm not sure exactly which case this is referring to, but would you screen this woman for symptomatic DM type 1, and how do you recommend doing this? So I guess the question is more, how do you distinguish, particularly with a younger patient, how do you distinguish or differentiate diabetes, type 1 diabetes versus type 2?
Yeah, very practical issue. Fortunately, most patients, it's pretty clear. With type 1, you can get overweight patients with type 1, but it's more common for patients not to be overweight. And they tend to be younger, and they've got usually ketonuria. And with them, you can measure C-peptide. And initially, you can get fooled if people are in the quote honeymoon phase because they're still putting out, but the antibodies. So you've got antibodies like GAD65 and the insulin antibodies, and typically with type 1, you're going to get some that are positive. And with type 2, we don't expect it. Now there are latent adult with diabetes type 2. So you can get sort of this in between, but the antibodies are the main way to check. Certainly, if you're acutely thinking, oh my gosh, this patient is significantly hyperglycemia has type 1, start insulin, so you don't get into trouble with hyperglycemia that spins out of control with DKA, if not hyperosmolar. And then you can do your antibody test to get an idea.
I've heard of reports of adverse outcomes. GLP-1 agonist is used in low output heart failure. Is there anything to that?
Interesting. Off the top of my head, I'm not aware of a study that showed that. That's not has not been a contraindication. So sort of like stay tuned. If they're studying this and gathering data, that'd be one thing. But the GLP-1 receptor agonists, again, don't help patients with heart failure. There's no data that they do. And that's the only class that does that is the SGLT2 inhibitors. But it hasn't been a contraindication.
Just following up on that, is that for both the heart failure with low EF and preserved EF, either?
Yes.
Okay.
Yeah.
Great. And then related again to the SGLT2 inhibitors, can you comment on its risks of osteoporosis?
Yeah. So if you have a patient who fits the demographics for a high risk of osteoporosis, let's say postmenopausal female, or has one of the many comorbidities that have been shown with it, like malabsorption or smoker alcohol use, then testing with bone mineral density with the DEXA scan and getting an idea right away with screening. And if their bone mineral density is good on scan, then at this point, you can counsel them to try and remove any reversible risk factor or improve what you can't reverse, and then go ahead and give the SGLT2 inhibitor. But if they have, significant bone loss, probably not the best category to use. Again, it's clinical judgment. If I had someone with mild decreased bone density, but significant diabetic renal disease, I would talk to that patient and say, here's the situation, it's good to work on the osteoporosis. At the same time, we're concerned about your kidneys and, share a discussion and maybe definitely want to optimize treatment for both. So, yes, we're looking for osteoporosis specifically if they're fit the profile for high risk of developing it.
For patients with NASH who's also overweight with their diabetes controlled on metformin, in addition to lifestyle medications, do you recommend pioglitazone versus a GLP-1 agonist?
Yeah, well, the first thing I would applaud you for even thinking about, fatty liver disease, because it's one of those things that kind of lurks in the background. So again, there's this fib for FIB, as in baseball, -4 index, which you can get online. I think University of Minnesota has one of them, which is a quick calculation with blood tests to see what would be the risk. And if they have it, clearly you want to do the lifestyle. You want to nutrition, weight management, exercise, stopping smoking. I would go to 0 alcohol because their liver is already stressed. And with that, if you're going for a specific medicine for the fatty liver disease, it's pioglitazone. The others haven't shown specifically to have improved outcomes looking at the liver, but the thiazolidine diones like pioglitazone has.
Okay. Any benefit to using TZD in patients with a history of stroke or with known cerebrovascular disease?
Not a benefit, not a risk. The thing about pioglitazone, that there was this concern about causing heart failure. It doesn't cause heart failure. It does cause, in some patients, increased volume, so you can get peripheral edema. So if you have an underlying heart failure, it could exacerbate it, and all the more reason to consider screening for subclinical heart failure. But it doesn't cause issues. Now, there was the other thiazolidine dione, rosiglitazone, which I think was taken off the market. If it's not taken off the market, I don't know anyone who would use it. That was associated with increased coronary artery disease, but that has not been the case with pioglitazone.
Okay. Is the oral semaglutide less effective in terms of weight loss compared to injectable?
Yeah, interesting. Off the top of my head, I can't recall a head-to-head study. There may have been one. So they both have been effective, but I think it's the injectable that has the more track record. But again, I can't give you data off that top of my head.
And then Brianne Lance would like to ask you a question directly. So I've just unmuted you, Brianne.
Looks still muted.
Sorry. Sorry. I think she's